Good morning, ladies and gentlemen. The plenary ran a bit late, and our main speaker, as you can see, was giving the plenary earlier on. So I might just have to go look for her. Unfortunately, our third speaker is out of the country. She's actually in South Sudan and is not going to be able to join us and can't even join us online because she's away from technology. So my apologies. Let me just see if I can find Prof. Krisha. All right, thank you, ladies and gentlemen. Thank you for your patience. I'm Professor Ratindlo from the University of Zimbabwe. I'm going to be the moderator. I'm supposed to be moderating with Lule from Ghana, I think. I don't even know the person. I hope they'll find their way here. So the title of this session is Shortening the Time for Access to New HIV, TB, and Malaria Prevention Technologies in Africa. And like I said before, we were supposed to have three presenters. The one who was supposed to present on malaria is not going to be with us today. So we've got two presenters. and that means we have a bit more time. So I'll allow them to go, not to go over slightly. You can have maybe 15 minutes instead of the 10 minutes that you would have been expected to deliver your talk, so that we have a bit more questions from the audience. So we'll start off with Professor Abdul Karim. I think I have to mention the name Quraisha in case some of you are thinking about Salim, but if you were at the plenary this morning, you will have heard her brief bio sketch. I am just going to talk briefly about the fact that she's an infectious diseases epidemiologist who's conducted a lot of research in HIV, in particular HIV prevention studies, and is the co-founder and associate scientific director of CAPRISA. I think most of us know CAPRISA. So you're free to go. I mean, I think we can talk from there. Do we have the mic?
Before I do that, I just wanted to flag for you some of the experiences. So what is the context for what we're doing? And while we're looking at new technologies in terms of and lessons from HIV, we have a long history of neglected diseases in Africa and generally in the global south and low-income countries. And these are very common challenges we face. And I think as Africans, we also need to take the lead in terms of responding to challenges that we face. And if we're going to have to wait for others to come up with solutions, we'll be waiting a very long time. And I think there are lovely examples that in this meeting and other meetings that highlight how we have a critical mass of scientists growing. We have an important demographic asset in terms of young people, where 65% of the population on the continent are under the age of 35. And we have new and increasing opportunities for young people to pursue careers in science, technology, and innovation, and to make their contributions in terms of ensuring outcomes in Africa. The next slide, please. And I did show the slide in a bit of a hurry this morning, but it's about the hepatitis B vaccine. And it's a story that we see over and over again in terms of having things that work and our inability to access it because of cost or supplies or whatever the case is. And you can see here from 1981, we have a really efficacious hepatitis B vaccine. South Africa was one of the first countries to adopt this in 1995. And we now have a growing cohort of children. In fact, it coincided with the year post-democracy in South Africa. We call them born-frees in more than one way, including access to comprehensive vaccination programs that included hepatitis B. One other country that more recently introduced this was Ethiopia in 2007. So when you count 40 years ago and you look at how many countries in sub-Saharan Africa or in the global south have access to the birth dose of hepatitis B, you'll see there's very few countries. And notably in sub-Saharan Africa, there's only 7 out of the 40 Gavi listed countries that have access to the birth dose of hepatitis B. In the meantime, we have quite a big hepatitis B epidemic, and that could be prevented. We're still trying to figure out modes of transmission. In Asia, for example, it's from perinatal transmission. In Africa, we don't really know what the mode of transmission is. A lot of unanswered questions. But here is a really good example of why we need to be putting time, attention, and energy to looking at how do we accelerate products so that we don't have this lesson that like history keeps repeating itself. Our speaker for malaria is not here, but I thought some of the notable events in the fight against malaria is worth highlighting as well. Malaria is something that impacts the continent quite substantially, and we have huge disease burden, a lot of morbidity, a lot of mortality, and we've been like really struggling to develop new drugs, and now, you know, finally we have some exciting news potentially of vaccines. And I think that something simple like impregnated bed nets, adoption, implementation, etc., has taken quite a while. And I think the Global Fund for AIDS, TB, and Malaria has been really critical in terms of catalyzing and strengthening our malaria efforts, and we're starting to see some of the rewards of that investment. May I have the next slide? And I wanted to say, now going to this point, next slide, please. That's coming to HIV, and so one of the first lessons in 1998, around 97, 98, the HIPNet 012 trial got underway. Very simple intervention. One, where you gave a single dose of nevirapine to the mother at onset of labor, and a dose to the infant within 72 hours of birth. In South Africa, we were going through a very challenging time. We had our second democratically elected president, who was actually challenging, does HIV cause AIDS? And at that time, we were seeing everybody that I knew and worked with or socialized with, we were seeing like 50, 60 deaths every week. Life expectancy had come down. Transmission rates from infected mothers to infants were about 30 to 40%. And it took the courageous leadership of the Treatment Action Campaign, led by Zaki Ahmed and others, to actually take the government to court. This was the first example of the use of the judiciary in terms of enabling access to a proven intervention. And I was very privileged to do the technical deposition for it. And so it was my introduction in the context of HIV, because I was born during apartheid, and I know and been part of the anti-apartheid movement and struggle. But this in HIV, this nexus between activism, advocacy, and science and evidence base and the use of the judiciary really came together. And this year, in fact, in a few days, TAC turns 20. And I feel one of the most important contributions was about enabling access to mother-to-child transmission and interventions. And as we look around sub-Saharan Africa, we see those rates have gone down to less than 2%. In many countries, we are talking about elimination of mother-to-child transmission. And you know, the other role the Treatment Action Campaign and other activists and advocates played was during the 13th International Conference, which for the first time was held in Durban, South Africa. And that was at the time when we were seeing countries, industrialized countries, making ARV treatment available and changing the face of AIDS from an inevitably fatal condition to one that's chronic and manageable. And in Africa, what we're seeing was decimation of the most active members of society, large numbers of orphans because we couldn't access this life-saving treatment. And that catalyzed the launch of the Global Fund for AIDS, TB, and Malaria, and the US government's presidential emergency program for AIDS relief. And it is amazing that the countries that contribute to Global Fund and to PEPFAR, these are taxpayers in countries where they don't have a big issue, but they thought beyond their countries to seeing that interconnectedness and shared vulnerability we have, and we're happy and prepared to make that investment. I don't think I have to highlight to this particular group the benefits that we've seen for treatment access and all the interventions that have gone in terms of strengthening infrastructure and our ability to do the kind of work that we just heard in the plenary from our speaker from Kenya. May I have the next slide, please? Now, in my presentation earlier, I said, when we're dealing with epidemics and pandemics and outbreaks, we're dealing with individuals, people, we're dealing with populations, and we're dealing with a particular socio-economic context. And we've learned with COVID that these epidemics are not just about the infectious disease and the organism that you're working with, but it's also about the impacts these epidemics have on already fragile and vulnerable economies. But when we do things and we find, a lot of the discussion in this meeting has been around how do we get uptake of PrEP? How do we have people staying on treatment after therapeutic success and when they're not so severely ill anymore? And quite often when we have these discussions, I'm quite struck that they don't include community. There's a perception that the community doesn't know what's going on. And mine is the most important key informants in anything that we do is the community that's most heavily impacted and who stand to benefit from anything that we're doing. And so this co-knowledge creation and partnerships and collaborations, we're seeing it within and between scientists, but we're not really seeing that at a very early stage when we're wanting to develop interventions and technologies, is to go to the people who will be using it, to the communities, and talk to the different gatekeepers, the different individuals. And we've seen in COVID, for example, how an important lesson in HIV, which is we don't do things without including affected and infected populations. And then we had a vaccine, and we were celebrating this, 6 efficacious vaccines in less than a year. And then what we were struggling with access in the first instance. And then when our countries did get access, we were struggling with uptake. And it was in all our use of virtual platforms and everything else, the people who spread misinformation and disinformation were much more effective in spreading information than we were in terms of communication. So this issue of trust in science, trust in governments, and trust in governments translate to what will citizens do and when will they do it? So that's another reminder. I want to go to the next slide, please. And I think quite often when we talk about intellectual property around products that we're contributing to in terms of trial participation or in terms of other types of measurements and so on, there's a whole big piece. We stopped talking. We had a very nice pandemic treaty that's become so watered down because whenever this discussion about IP comes up, we kind of like, no, we can't do this. It's going to kill industry, etc. But in fact, with antiretroviral treatment, we did have generic drug production that brought costs down. But we also had pharmaceutical industry coming in and reducing the price of drugs. We had 2 tiers, labeling, all kinds of things. And I think there was a better appreciation of what the cost of inaction is and the security threat that the decimation of populations we're posing, that we had something very different happen. So when we start talking about interventions, even if we have proven interventions, as policymakers and other decision makers need to make decisions, they get stuck with how much is this going to cost? And so this is something we know with generics. You've got good quality biosimilars and that they are very, very cheap and they're able to meet the demands that we have in Africa for high volumes and consistency. So I'm just about to wrap up and I want the next slide to show you that when you have an idea to develop a product, there's a very clear development pathway and pipeline in terms of the sequential steps that need to be taken. And my recommendation is that we do an end-to-end approach. We don't wait for a product and then think about, do we have enough quantities? We have enough experience now from HIV to know where the population need is, what our demand is going to be, and that at what stage do we start those discussions about manufacturing to scale? What stage do we start talking about pricing and so on? And mine is, it starts right at the beginning with all of the key partners and stakeholders throughout. And we do research, and we are used to, and ask me, I'm like an expert at failure. I spent 18 years failure after failure trying to find a woman-initiated technology. And even then, when we did find the first proof of concept, it wasn't good enough for public rollout. But the point is that when you do a trial, you give it your best shot. In giving it your best shot, you still don't know whether it's going to work or not work, and or be futile. And you don't want something safe but not efficacious. You don't want something efficacious but unsafe. But that each of these give us important lessons, and it's never too early to start thinking about, especially now where there's a whole open pipeline of PrEP products, both in terms of small molecules and biologicals, that we need to start early enough in the hope and in anticipation, even such efficacious products that they may not see the full trial through. A DSMB may pause it early, and then you're not sitting there and struggling. What do we do for clinical trial participants and the communities? What do we do about key populations that may benefit from this? And then we're not thinking about, we have 7 years to the 2030 goals, and is this a game changer? And how do we pull this and change our thinking? And then my last slide, please, which is, I just want to leave you with something like simple, A's, like 4 A's. And think about, how do we improve affordability? How do we improve accessibility? How do we increase availability? And how do we improve acceptability? Right, so access, affordability, availability, and acceptability. And each of these things, if you use the end-to-end approach, you start that early enough. I have worked with many communities, rural, peri-urban, and urban communities. Have worked with men and women, with young people and old people. And I am impressed with how much they understand about the scientific method, and that they with me, and when we have a failure, they say, shame, didn't work this time, we'll try again. And they volunteer, and we see that across Africa, how participants volunteer in our trials, even though we can have negative results. And we expect negative results, because if we knew the answer, we don't need to do these trials. And I think just don't underestimate people's knowledge. Like, don't start with the regulatory authorities too early. They're going to license the product. And sure, we must start that early discussions. What do you need? Are we collecting the data? Are we collecting enough data so that when they have to review this for licensure, that's not when you're coming back and saying, where's the woman? Where's the pregnant woman? Where's the adolescent data? Where's the data here? So that early discussion in anticipation of a positive result never goes to waste, because we all learn to communicate with each other, converse, and it's no conflict of interest to be having a discussion with your regulatory authority, whether it's about medicines control or whether it's around ethical considerations. And the sooner you start that, the better. As I've already underscored, it's with community, but also with governments. It is amazing for me. It takes sometimes 5 to 10 years to do a trial. And then the only time, and the first time, scientists are going to government about that study is when they have a result, and suddenly you're expecting the government to be implementing this. And I don't think that's like a fair expectation, but we need to start preparing government, because they do 5-year budgets, they do 10-year budgets. Treasury needs to make these allocations and so on. So if they're expecting and anticipating, they can have it as a line item. they can have it for policy and decision making, etc. So I hope that gives you some thoughts and ideas about how we can accelerate this process, and that in the many challenges that face us, we don't have a situation where we have a bucket load of interventions and we're sitting on it because we're not implementing it, and years go by and people who need to benefit don't benefit. Thank you very much.
Thank you, Prof. Thank you, Prof. Krish. Dr. Samanika, it's your turn now. Dr. Samanika is a Zimbabwean medical doctor who has been involved in clinical trials for more than 18 years. I'm sure some of you may have seen her presenting in some fora here. She's also a clinical epidemiologist and now specializes, well, I thought it was just TB treatment and prevention, but anyway, we'll hear from you. Dr. Samanika, you have the floor.
Thank you very much. I think it's working, right? Okay, yeah, it is working. So next slide, please. So the title of my presentation is Novel TB Preventive Regimens and Opportunities and Challenges for Scale-Up in Resource-Limited Settings. So we do know that TB remains a major preventable, a major but yet preventable global health problem, with 10.6 million people being diagnosed of TB in 2021 and 1.4 million deaths due to TB. And this number was actually more than double the number of deaths due to HIV reported in 2021. So now let's focus on TB infection and its prevention. A quarter of the global population, which is about 1.7 billion people, are estimated to be infected with Mycobacterium tuberculosis, the bacilli that causes TB. And this is really a huge reservoir of infection that needs to be addressed, because if it's not addressed, the talk of ending TB, we may have to go a longer way, because this is quite a huge reservoir. And on average, 5 to 10% of people who are infected will develop TB disease over the course of their life. And the highest risk is actually during the first year after infection. So for those who love visuals, this is just showing to the left lung, I think, is showing well-contained bacilli. And to the right is actually, oh, sorry. Next slide. Next slide. Okay, so I'm talking about this for those who love visuals, the latent TB versus TB disease, that at the lung where the defense mechanism is actually well contained, and to the right you actually see that there is TB disease. So next slide. So WHO guidance recommends TB prevention treatment for specific categories of people. As we know, people living with HIV who are at the highest risk of developing active disease, household contacts of bacteriologically confirmed pulmonary TB cases, and some clinical cases that are at risk. For example, those that are receiving dialysis are at increased risk, and particularly children less than 5 years who are at a particular risk of developing more severe forms of disease like TB meningitis and disseminated TB disease. And there is evidence that TB preventive therapy reduces the incidence of TB and mortality in people with HIV up to 37%, and that is independent of antiretroviral therapy. Next slide. So in 2020, the WHO updated its guidelines to include newer, shorter regimens that contain rifamycin, that is rifamycin-based TB preventive therapy, of course, still including the isoniazid, which has been historically the preventive therapy for TB. And so the other newer ones containing, not really new, but those that were really introduced as possible regimens to be used for TB prevention: the 4-month daily rifampicin 4R, the 3 months daily rifampicin plus isoniazid 3HR, the 3HP, which is 3 months of rifampicin plus isoniazid, and the ultra short one, which is monthly rifampicin and isoniazid. And for those patients with MDR TB disease, levofloxacin daily for 6 months. Next slide. Next slide, please. So these shorter regimens, they seem attractive, and there is an increasing body of evidence around their safety, acceptability, and even completion rates. And they provide their efficacy is around 60 to 90%. Next slide. So this slide is really showing the evidence, evidence of the 3HP trials that have been adopted by WHO, that they were non-inferior to INH and they were safer than INH, and also that they were safer in patients living with HIV. Next slide. So this is evidence for the short 1HP, the 1HP, where patients just receive isoniazid and rifampicin for 1 month. This is just the evidence as well. Next slide. So coming closer home, Zimbabwe has actually adopted and is implementing 3HP, 3RH, and continues with 6 months of isoniazid and 6 months of levofloxacin for MDR TB contacts. Next slide. However, despite all the evidence, TB prevention scale-up in TB programs has been low, and the gap is particularly alarming or concerning in children. I think throughout this week, we have been hearing about TB updates in TB treatment programs and the gaps that are there, and how countries can close these gaps. And early this morning, we've heard from Prof that they are target goals versus targets, and how are we meeting our targets, and how are we setting up our goals. Next slide. So in terms of global progress in provision of TB preventive therapy, the UN high-level meeting in 2018, they set up these goals and targets. But if we look at this slide, which is data from TB Global Report of 2022, the target of 30 million people to be on TB preventive therapy was not met. Only 42% were treated by 2021. However, people with HIV really, they surpassed the targets. And probably this is due to the integration of the HIV TB programs in many settings, which is easier to actually get this participant who's HIV infected and integrated into TB programs. When we look at HIV household contacts for those aged less than 5 years, the target was 4 million, but only 40% were on TB preventive therapy, and less for those that are aged greater than 5 years, and these are household contacts. I guess the challenge of getting those people into care. Next slide. So what are the perceived obstacles to TPT rollout? What are the implementation challenges? Recent evidence just shows that there's issues of access to patient-friendly formulations, including children, particularly for children. They note the difficulties of ruling out active TB. That is for the household contacts. For the person with HIV, we know that according to the guidelines, they are eligible for TB prevention. But accessing that household contacts, we need extra clinical examination, extra evaluations to be done. So we need to exclude active TB before we can actually put that patient on TB preventive therapy. There are some fears of development of drug resistance, and again, perceived provider beliefs of drug toxicities. These may not be perceived because we have seen hepatocellular damage, hepatocellular injury in patients receiving even isoniazid or rifampicin-based TB preventive therapy. But so they are not perceived, I think, is the concern about how we will be able to manage those side effects once we put those patients on therapy. Again, the other challenges that are cited are competing priorities to deliver antiretroviral treatment, because this is the same team that is looking after HIV infected individuals, and now we need to also put these patients on TB preventive therapy. And one of the other implementing challenges that are cited are cost and resource limitations for patients and providers. And this is related to contact investigations. Like I've said, for patients, for household contacts, they need to be screened. We need to rule out that this patient doesn't have TB before we can put them on TB preventive therapy, and the issue of stock outs of those agents that we'll be using for preventing TB. Next slide. So another, one of the other challenges or perceived challenges concerns special populations like pregnant women. There's data from a randomized trial that showed that safety and efficacy, appropriate and timing of TPT in pregnant women may be an issue. However, WHO, with recent data, recent evidence, they considered that deferring IPT to the postpartum would actually deprive these women of the protective effect of the TPT, which they need, and they are at risk at that time. Next slide. Again, the other challenge cited is limited evidence on the best TPT regimens for drug-resistant TB. WHO provides conditional recommendation, and some studies are underway. Already, levofloxacin for 6 months is recommended for those household contacts of index cases of MDR TB. So, treatment options for multi-drug resistant TB will be central to the contribution to contribute towards the TB elimination. So, next slide. So this next slide was referring to the studies that are underway. So we have the ACTG 5300B, or the Phoenix study, is actually ongoing. It's a study that is comparing delamanid and isoniazid of household contacts of patients who have MDR TB. It's ongoing, and I'm proud to say we are also conducting this study in Zimbabwe. And its completion is expected first quarter of 2024. And the VQueen and TB CHAMP study, these results were released recently at the Union World Conference on Lung Health. And really, we are happy to really have these results, and we hope they will be they will contribute to WHO guidelines. So in the TB CHAMP, they were enrolling children regardless of TST or HIV status, and the comparison was between levofloxacin versus placebo for those household contacts of MDR TB. And the TB CHAMP study showed that levofloxacin was able to avert 56% of MDR TB disease, whilst the VQueen study, levofloxacin was able to avert 45% of MDR TB disease. Next slide. So what are the opportunities to scale up TPT in HIV programs? So we can talk about implementation research. So the impact for TB, which is funded by UNITAID and really led by the Oram Institute, had the aim of shaping market for 3HP and catalyzing scale up of 3HP. And this was really a global preventive program in 12 high TB burden countries. And these included Brasilia, Cambodia, Ethiopia, Ghana, India, Indonesia, Kenya, Malawi, Mozambique, South Africa, Tanzania, and Zimbabwe. So there was a common protocol that was implemented across all these sites, and the objective really was to assess the feasibility of scaling up 3HP in people living with people living with HIV and household contacts of age less than 15 years. And they also wanted to evaluate novel models of delivery to support scale up, conduct pharmacokinetic studies, and evaluate programmatic implementation in some of sentinel sites in those 12 high burden countries. So in Zimbabwe, next slide. So in Zimbabwe, this study was implemented at 20 health facilities, which was spread across 5 provinces and 15 districts. And initially, due to COVID, they'd enrolled at the study had been implemented at 5 sites, and then completed later on after COVID. So this, in summary, 3HP initiations accounted for 60% of all TPT initiations in this initiative. And the completion rates were 82% for all the participants that participated in this. And it's important to also note that uptake in children was very low at 4.7%. However, TPT uptake amongst ART-naive people was 52%. Okay, it's time up. Okay, this way I was just going to give the example of implementation research that can actually foster what we, the uptake of TPT. I'll move fast. And in terms of delivery, in terms of modes delivery, we can really ride on, and HIV programs are really, have done well. We've done well in HIV. We've done well in integrating HIV and TB. And we can actually ride on this in terms of provision of TPT to those who need it. So in this pilot study, which was actually done in Zimbabwe, where they looked at feasibility and acceptability of using the already models that are in existence, that are being used for HIV. They wanted to assess the acceptability of this fast-track model to deliver 3HP for TPT, whilst aligning HIV visits and providing multi-month dispersing for 3HP. And the conclusion was that it was acceptable and tolerable. However, patients did report some tolerability challenges, but the uptake was high at 98%. And therefore, the conclusion was that scaling up of this approach could expand TPT coverage in Zimbabwe. And this is actually being also implemented in other regions within. Let me move fast. And in terms of differentiated service delivery for TPT, another study done again in Zimbabwe. Next slide, next slide. Next slide, next slide. Next. Okay. Yes, so they also looked at acceptability of community-based tuberculosis preventive treatment for people living with HIV, again here in Zimbabwe. So we do know that there are already existing modes of delivery of antiretroviral therapy for those who are stable on ART, and community ART refill groups are already in use. So they wanted, the authors wanted to check with the community whether it was acceptable to integrate TPT into community ART refill groups. And yes, 96% of participants were in support of integration of TPT in the community ART refill group. So in summary, short-course TPT regimens offer clear advantages in terms of improved adherence and completion rates. Some of the barriers to the worldwide expansion of TPT relate to uncertainties about how best to roll out interventions, how to find people at risk of latent TB infection, how to test them and help them start and complete their treatment. However, in the era of differentiated care, programmatic scale-up of TPT can be supported with the creation of integrated care models that incorporate TB screening and provision of TPT without increasing frequency of clinic attendance. So I think I thank you. Last slide, I'm acknowledging Dr. Apollo from the Ministry of Health, Professor Margaret Borok from the University of Zimbabwe. Thank you.
Okay, thank you, colleagues. I'm sorry we have run over our time. I thought we were going to have a bit more time because we have one less speaker. But we've had some ideas about how to shorten the time to adoption of new technologies for HIV and TB. We didn't hear about malaria. But I think the bottom line is, from what Prof here said, is the researchers, when they start conducting a trial, they really need to start thinking through how, when the results come out, how they're going to sell those to our governments and what needs to be in place, in terms of acceptability, affordability, availability, which is one of my interests as being interested in essential medicines. Really, we need to make sure that these technologies, at the time that they're being tested, we are already thinking about how we will introduce them in our settings. Thank you very much. I'm sorry we won't have time for questions, but I hope you can still sort of get in touch with the presenters and ask them questions in between this session and the next one. Thank you. Thank you very much.